10:31. So I think we're going to make a start with today's seminar. I know people are still coming in, but we've got quite a lot of ground to cover. So we'll get started. First, welcome everyone to our webinar dedicated to an introduction to health economics. My name is Cristina Fernandez-Garcia, and I'm a health economist based at Newcastle University. I've worked on economic evaluations largely all my career in health economics. I've worked in clinical trial settings, but also in the design and evaluation of atypical interventions delivered at community level and also policy rollout programs. I'm also a specialist advisor for the Specialist Centre of Public Health and provide general and health economic support there with my colleagues at the centre. We've got Louise, Alex and Ellie from the centre joining us today that I can see there. We're very happy to provide advice on the design of your research. So if you need some advice after this webinar, please reach out to us. I've got my email address there, and you are pleased to contact me directly or via the centre. Today during the webinar, please, if you do have questions, post them to the chat, and I will address the questions towards the end of the webinar. If we run out of time, we'll take note of your questions and we will create a question and answer document that we will circulate. After this, we will circulate that with the slides of the webinar and a recording link to the webinar as well, and also a feedback form that we would be very grateful if you could complete and give us ideas for future webinars and just tell us how we did today. Okay, so I think we've got most people here, so I will make a start now with the webinar proper. Right. So today, the objectives of the webinar is just to give you a very basic introduction to health economics that would include some basic economic concepts to understand why health economics might be important in the field of public health, and to outline the main full health economic methods. I won't cover all of them, but the ones that are really considered full evaluation methods and that you might find useful for evaluating public health programs or interventions going forward. It is quite a basic introduction, so I apologize to those who already have quite a bit of health economics knowledge, but I wanted to assume that nobody really knew what health economics was. So what is health economics? So health economics is the study of how we as a society make arrangements for the production and distribution of goods and services. So it helps us to decide what to produce, how to produce it, and importantly, how to distribute what is produced. So that's the concept of economics in general. When we talk about health economics, it's applying that economic concept to the discipline of health. NICE provides a nice definition of what the aim of cost effectiveness should be. And it is in the view of health economists to help decision makers choose interventions and programs that maximize the health benefits to the population given the resources available, ensuring that waste is minimized. Before I get into the different economic evaluations that you can use, it is important that we understand some basic economic concepts that underpin those evaluations. That would be the concept of scarcity, the margin, effectiveness, efficiency, equity, and opportunity cost. A scarcity, I think, is very clear to everybody what it might mean is that resources are finite. But however, the demand for health is potentially endless. And the demand for health is materialized in demand for healthcare or public health interventions. But what people want is better health outcomes, and they do that via accessing public health interventions or other healthcare resources. We are concerned with the concept of effectiveness, which is, in short, how well are we doing things? And in health economics, we combine that with efficiency, which is maximizing the benefits in the face of those scarce resources and the scarce resource of, public health budgets or healthcare budgets in general. And then we also care in health economics about how those resources are distributed in society and about the fairness of how they are distributed. Opportunity cost is it's a key concept in health economics, and it relates to how we make choices regarding what to do and what not to do, and is intrinsically linked to priority setting. And priority setting is the same as rationing. So in priority setting, we decide what to do, but at the same time, in deciding what to do, we're deciding what not to do. So we're concerned about investment and disinvestment at the same time, because investing in one initiative or in one program means that those resources that we're investing will not be available to invest elsewhere. If you are a decision maker that needs to decide whether to launch a smoking cessation program or an initiative to improve physical activity, you may have to choose one over the other if your budget is limited or fixed. Opportunity cost reflects the true cost of a public health program, which is defined as the benefits that might have been enjoyed if those same resources were used in a different program. That's how opportunity cost is viewed. So what are the benefits that are foregone from not doing another initiative? And the aim of decision makers is to minimize that opportunity cost in making those decisions. This is slightly different to the typical cost definition in accountancy. So here we're interested in what would have happened if we'd invested differently. Just to bring this concept home to you, and I'm borrowing from a concept in healthcare, a cost of a hip replacement is roughly £18,000. So as a health economist and a decision maker, you need to think, well, what else would £18,000 buy you? Mm-hmm. And in this case, it would buy you a treatment for one heart valve replacement, 3 planned cesarean sections, treatment for 6 minor strokes, treatment for 30 minor hand injuries, or for 60 minor cataract operations. And that is the concept that we're operating in. Doing one thing will stop us doing other or a number of other things. Okay. Then we have the concept of the margin. And you will see later on that that is an important outcome or output in an economic evaluation, because decisions really are typically made at the margins. So we don't focus on the total cost of a new intervention. We're interested in what the change in investment or the change in cost, what that generates in terms of change in benefits. So we're thinking about marginal quantities rather than average quantities. It is more useful in decision making because you're already doing something. You're already doing something that generates a set benefit. So you want to know, if I change my investment here, how is my benefit going to change? It's really a simple decision rule in health economics. If the marginal benefit, if that changes benefits, is bigger than the marginal cost, then you would consider that what you're proposing is cost effective and it should go ahead. Another consideration I slightly touched upon before is how is it that we're going to distribute those resources, not only in terms of what to fund and what not to fund, but when we fund something, how is that going to be rolled out? Who's going to benefit from those interventions? And for that, it's important to distinguish the concept of equality from the concept of equity. I really love this image because it really highlights that. Equality in this case would be to give everyone the same bike to go and cycle in the park. But of course, people have different needs, and giving them the same bike is really not going to achieve the same outcome, which is improve physical activity, and in this case, going for a ride. So in equity, what you do is you adapt to people's needs and give them what they need according to what we adjust what you give according to their need. And that leads to two different concepts of horizontal equity that is worth bearing in mind. Two different concepts of equity, apologies. One of them is horizontal equity, which is ensuring that people in equivalent circumstances are treated the same. So if you have a smoking cessation program, let's say, you'd want to open it to everyone who wants to quit smoking. So that would be horizontal equity. But there is another level of vertical equity, which is treating individuals or community who are unequal differently in whichever equity relevant variable that is, in a way that you are meeting the relative disadvantage. Just to give you an example, you may decide that different socioeconomic status is an equity relevant variable and that you need to treat people differently. So in your smoking cessation program, it may be that you need to adapt the program to attract those that come from lower socioeconomic levels because their uptake is generally lower, and because you need perhaps incentives to make them engage with the program, etc. And that is something that you can incorporate into your economic evaluations. Now, I'm going to move on to the key ingredients, what you will always need in the design and conduct of an economic evaluation. So first of all, you need to measure the cost of your intervention and program. And for that, it's very important that first of all, you define the perspective. So whose cost are you measuring? As a decision maker, it could be that you're just interested in the cost to local government or to the health service provider. Or you might want to go broader and you want to see what are the costs to the patient, to the employer, to the economy in general. But this is something that you need to be very clear about from the very beginning, because if you're not, you will be identifying the wrong type of resources and therefore the wrong cost to go into your evaluation. For example, if you decide what I really care about is the public sector and the costs that are incurred by the public sector by the rollout of this intervention, you might want to include the costs accrued by primary care, by the NHS, by secondary care, by personal social services, or by the local government, or by whoever is paying for the intervention of the program. But you need to be very clear on that from the beginning. A wider societal perspective can also be incorporated. And actually, that is more and more incorporated in evaluations nowadays. And that would also include the cost of an individual. And that would be the lost wages from attending screening programs or any other intervention that you can think of, the travel cost of engaging with a program, also the costs incurred by the relatives that are accompanying that person to a service, childcare costs, transport, etc. It can be very wide, but it's something that you need to think about, like I said, and I would really want to bring it home from the beginning. Of course, it might not be practical to include every single line of cost that could be incurred with intervention. And that depends very much on the magnitude of the cost, the context, again, the perspective, and the time horizon. Time horizon is important as well. Is the kind of intervention that you're thinking of concrete and is just going to deliver over a set period of time, over a month, 2 months, a year? Is it going to continue longer in time? Is it over 5 years, 10 years? If that is the case, you have to take that into account and incorporate that into your evaluation. The next ingredient would be the outcomes. So you're measuring your costs, but really you want to know what is it that you're getting from your money. And those are the outcomes. What outcomes are of interest to you? These are the benefits that are derived from your intervention and program. Also, the perspective here is very important, and it often differs. The perspective may be different from that from costs. Typically, you care about the costs from those delivering the intervention, but the benefits are accrued by the population of interest. Okay, so decreases in asthma admissions if you are going for an air pollution program in a city, or COPD instances, and it really does depend on what you're trying to evaluate. So we need to identify those effects, and then we need to measure those effects. So by what degree those are changing in hospital admissions, or changes in a smoke uptake, or changes in the screening uptake. Let's just say that you're rolling out a cancer screening program or a vaccination program as well. And then you have to assign a value to those effects. Excuse me. And that could be actually a monetized value. You can do that in cost-benefit analysis, and I will chat about that a little bit later on. The time period is incredibly important as well. In the same way that I said you need to have a time frame when assessing your costs, so do you when it comes to assessing your effects. This is particularly important for preventative public health measures. Like your measure might be delivered today, but the effects of that preventative measure might not be seen for a number of years. And it's important to really establish that, because it may make the difference between a preventative public health measure being considered cost effective or not. If you're not able to capture the outcomes that you think you're going to accrue in the future because your time horizon is too short, it may work out that the intervention is perceived as not cost effective when it could well be if the time horizon had changed. For all of that, it is incredibly important that you develop a logic model. This is for any kind of evaluation, but for your health economics evaluation, even more so. You need to know how your intervention operates. You need to know what inputs are going into that intervention, the activities it generates, who's involved in delivering that intervention, and what that intervention is going to generate, both in the immediate and in the longer term. You need to know all of this, and this will clarify what ingredients, the cost and the effects, will go into your economic evaluation. You will make a number of assumptions. You'll have a hypothesis on how it works, and also it's important to take into account the external factors that may be contributing to that change in outcome going forward, or the internal factors. It could be differential uptake in populations. It could be that there is another intervention happening elsewhere that is actually contributing to a change in the same outcomes that you're interested in. And that, when you know that, you know whether you'll be able to account for that in your economic analysis and your analysis in general. So incredibly important that you have this from the very beginning, because an economic evaluation will only be worth its value depending on how well it's been designed and everything that you've put into it. So now I'm going to tell you about the full economic evaluation framework. You've got your ingredients, you know what you're evaluating, and now you've got your tools. You incorporate those ingredients that we've been talking about into different tools. And those tools will vary. And they will vary on the kind of outcomes that you're interested in, and vary in the kind of data that is available to you as well, and in the kind of information that the decision maker is interested in. So I've put on this table the three main types of economic evaluations, and they're not in any specific order or hierarchy. Like I say, it depends on what you're trying to evaluate. The first one that I've put is cost effectiveness analysis. Here, the costs will be valued in money. They'll be monetized while you go in. And the outcomes will be generally a clinical outcome, but it could be any kind of outcome in a way, but in these natural units. So it could be changes in mortality, it could be changes in cases of respiratory disease, it could be changes in asthma-related admissions, it could be changes in level of pollution. Just it's for you to decide, and it depends on your intervention. And the output that you will get from this evaluation, it will tell you the cost. So how much does it cost you to get an asthma-related admission decrease by 1 unit, let's just say, and that would be your incremental cost-effectiveness ratio. Cost per asthma attack avoided could be one of them. Okay, and then the decision rule, whether it's cost-effective or not cost-effective, in cost-effectiveness analysis is really up to the decision maker to decide whether that's value for money. Okay. An extension of cost-effectiveness analysis is cost-utility analysis. And here we also have monetized cost, monetized resource use or costs. And then in the outcome part of the equation, you have a quality of life measure. And actually, it's a generic measure that combines both the quantity of life generated by the intervention, weighted by the quality of life of that intervention. Okay, many of you may have heard of the QALY, and that's what it is. 1 QALY is equivalent to a year lived in perfect health. And you measure that quality of life with a different set of questionnaires. Typically, the EQ5D5L is a questionnaire that measures different dimensions, 5 dimensions of quality of life. You get a utility value and you weight the length of life that is gained by that quality, by that utility value, and that gives you a quality adjusted life year. Here, the decision rule is perhaps clearer because it's nice indicates that any intervention that generates 1 quality adjusted life year for less than £20,000 is considered cost effective. So here the decision rule is more straightforward, if you like. And then we have the cost benefit analysis, and it is the broadest kind of analysis that we have, and perhaps one of the better suited to public health initiatives, because you can combine a number of outcomes, a broad set of outcomes, and it's all measured in monetary terms. So the costs are money and the outcomes are valued in money. And you say, well, how do I measure that? Well, there's different ways, but one of the most typical ways is to establish a willingness to pay amount. And for that, you have surveys, you ask people, you also have published literature that can help you with this. But here the output are your costs monetized, like their costs always are, and your outputs monetized too. So if the monetary value of your benefits is bigger than the monetary value of your costs, then generally you would think that is cost effective. Okay. Just to sum up, when it comes to choosing your framework, cost effectiveness analysis is good. You can choose the outcomes that are relevant to your decision, but because it's not a generic measure like the QALYs or the monetary benefits, it's not good for comparing interventions across the system or across different systems, comparing their cost effectiveness, and it doesn't capture impacts on quality of life. Cost utility analysis is great in the sense that you measure QALYs across a different broad range of interventions, and then you compare their cost effectiveness. And so is cost benefit analysis, because you're comparing monetary values and the monetary benefits against costs. You can compare the effectiveness of a wide range of intervention. Now, I talked about the incremental cost effectiveness ratio, and that's about bringing the cost and effects together for the cost effectiveness analysis and the cost utility analysis. And the formula for the incremental cost ratio is the changes in cost. Remember when I talked about the margin, the changes in cost divided by the changes in effects, and that gives you the ratio. And that gives you that ratio that we talked about. If it was less than £20,000 per quali gain, that's the ratio that you would get with this figure, with this formula. How do you present this to a decision maker? Well, there's two very useful tools in health economics. This is the cost effectiveness plane. And your comparator would always lie here in the middle. So you're comparing an intervention in relation to another. And the new intervention could be more costly and more effective. And most interventions fall within that gradient. And then the decision rule might depend. It could be, like I said, if it was £20,000 per quali, the decision maker might consider it cost effective, but it may vary. It could be that your new intervention is less costly and more effective, in which case, well, it's a no-brainer, like they say, isn't it? You should choose the new intervention. It could be that the new intervention is more costly and less effective, in which case you would exclude it. Or it could be that it's less costly and less effective. And in that way, it really does depend on what the aim of the decision maker is. They might not care that the new intervention is less effective. It's rare, but they might not care. They might care about saving money, and they might decide, well, I'm actually going to go with a less costly option. Another useful tool that you have, and this brings together the equity concerns, is that you could make an equity assessment and incorporate that into your cost effectiveness analysis. That's beyond the scope of this webinar, but I'm going to show you how that could be used. You could incorporate those two together and assess it jointly and decide whether or you have the outcome that an intervention is cost effective and it improves equity, in which case most decision makers will go for that. It could be that it's not cost effective, but it improves equity, and that might actually be a valuable bit of information to a decision maker if they want to target a specific group regardless. Or it could be that it's cost effective and harms equity. Again, it could be that they go for that. Or it could be that it's cost ineffective and it harms equity, in which case I can't, who knows, but hopefully decision makers won't choose that kind of intervention or program. To round up, just some key concepts, just to remind you when conducting economic evaluations. Define your perspective clearly. Who's caring about the cost and who cares about the outcomes, okay? You need to think about that very carefully. Identify a suitable comparator or a counterfactual. So what is it that you're comparing it with? Are you comparing it to what happens? Is it that nothing happens at the moment? That's fine too. You can still establish your comparison there. Make sure that you have all the data needed on all relevant longer-term outcomes, especially important for public health prevention initiatives. If there's missing data on resource use and effects, think about what techniques you might use to mitigate that, or how that would affect that cost effectiveness of your intervention. Discounting as well. If you're conducting an evaluation that goes beyond 1 year, you need to establish that preference for benefits and costs to occur now rather than later. So you apply a discounting rate for those costs and effects that go beyond 1 year, which is typically 3.5%. And then test that your results are robust. You might want to conduct some sensitivity analysis and just vary the level of resource needed to deliver the intervention. Think about the uptake, change uptake rates, think about how the intervention will be delivered in different settings and how that affects what goes into the economic evaluation. Just have a think through about how generalizable these results are, how robust they are. And lastly, if you want to think about what goes into a good quality economic evaluation, check the CHEERS checklist, which is a 28-item checklist that outlines how and when these reporting starters should be used. Okay, just think about it. It gives you a very good idea of what needs to go into a good quality economic evaluation. I think I've hit the half-an-hour mark, and I'm sorry, I won't have time to go through the questions live on this webinar, but I will take a note of those on the chat. And I hope you found this useful. I know it's a lot of information there, but if you have any questions from this seminar, or if you need our help to help you design an economic evaluation, please get in touch with me and we'll be very happy to help you. Thank you all for attending, and I hope you've enjoyed it. Thank you.